So tonight we are in our third session of this series. We had sports last week, and this week's going to be adult reconstruction. So our adult reconstruction group is Dr. Cui, Dr. Brown, and Dr. Brown, who do all of our total joints here at UVA. And it's my great pleasure to introduce Dr. Quanjun Cui, who is the total joint specialist. He's also the vice chair of research here at UVA. And so any research projects we do here kind of run through him. He's just an icon of this place. He's just a wonderful guy, one of the nicest guys you'll ever meet. And he's got a nice talk tonight on total hip arthroplasty. And so after we do that talk, Michelle Q, if she gets out of the operating room, is going to do some cases with us. And then Thomas Moran is going to finish us off talking about our curriculum and talking about the didactics and our rotation. So without further ado, I'll introduce Dr. Quanjun Cui, who will be talking about total hip arthroplasty. Dr. Cui, the floor is yours.
All right. Well, thank you very much, Dr. Grassman. Thank you for that wonderful introduction. Hello, everybody. Just call me Trey. So it's easy to remember. That's a Chinese name. You know, actually in English it's hard to pronounce. So Trey, that's all you just remember. And I want to welcome you to this fantastic program organized by Winston. You know, we actually have logged in several times. I really enjoyed the program. So before I talk about total hip replacement, you know, I have been in Charlottesville and with University Virginia for 26 years. I want to share some of my experience with you, and hopefully can draw your attention and you like our program. You know, University of Virginia just celebrated its 200-year birthday last year. And, you know, this is a university of, you know, Thomas Jefferson. So he built this place. If you look at his mission, basically, the institution is built on a illimitable freedom of the human mind. So everybody, you know, join the team here at UVA. Basically, you have a freedom. You know, we want to bring your best part out to contribute to the team, to the community. So this is the University of Virginia. My personal experience, I think this is the best, one of the best university to study, to get trained. So spring and fall is the best season in Charlottesville. You can see the picture. This is a rotunda, you know, graduation party always here. And weekend you can take a walk over there, you know, walk your dog over there. And fall is a beautiful season, so colorful. And unfortunately, this year, you guys cannot join us. But most of the time, you know, our other set of rotators will spend time here, enjoy the colorful season here in Charlottesville. And this is the new medical school has been, you know, almost 10 years, but it's still state of the art building. You can see this 300 interactive teaching experience, and you know, all our trainees can enjoy this you know, facility. As you all know, University of Virginia is the level 1 trauma center and also tertiary referring center. And here is the new helicopter pad, and here is a new tower of the you know, ER building. Actually, on the first floor, supposed to be orthopedic floor, but COVID got here in February and delayed our move in April. But next year, I hope after vaccine available, we'll be able to move in. Plus, I'm sure Dr. Grassman will already show you the new orthopedic hospital at Ivy Mountain. So your class is going to enjoy the state-of-art, you know, the facility here at the University of Virginia. Charlottesville is a small town, but it's the best place to live. You and your family, if you have a family, is going to love to spend 5 years here. You see this picture, this is center, you know, of this picture is the University of Virginia and a medical center. And surrounded by Blue Ridge Mountain, Carter Mountain. It's a beautiful place to visit, to enjoy outdoors. Downtown Mall, you know, and a corner we have Connolly's restaurants. And if you look at, adjacent area within 10 miles, radius, you have more than 25 wineries and breweries. So you can definitely enjoy the vineyard. If you don't like wine, here's the Jefferson vineyard, very good wines, and you can hike on the Blue Ridge Mountains, watch the beautiful sunset, and also game days. You can enjoy the game together with team physician Dr. Grasamy there. We have a lot of activity there. Otherwise, you can play golf at a university golf course at a Birth Head. And of course, the balloon tour is very attractive. And all the Sundays, you can visit King Family Vineyard to watch a polo match. And this is not a polo match, but this is one of my patients. He sent me this picture. Virginia is a farmer country. So many farms with horses and cows, you can see. But can you imagine this, more than 60-year-old lady riding her horses with a hip replacement? So that's the beauty of the total joint replacement. So, Charlotte is one of the best places to live, and you and your family is going to enjoy it. But most importantly, I wanted to share, orthopedic department with a leadership with Dr. Chahabara in last 8 years, and with a new program director, Dr. Grasamy. This place is booming. And if you look at our mission statement, we wanted to be a leader in 3 pillars: patient care, orthopedic education, and research. So without you, we cannot achieve this goal. Residents definitely part of the team. So we want you to get involved. And personally, I'm so proud to be a team member. You can contribute and work with you, grow together. So adult Recon team, we have 3 surgeons. In the middle, this is Dr. Thomas Moran. So he's the senior partner. He's also fellowship director. Actually, he was a former residency program director. He's a great mentor and a great teacher. James Brown is he's a younger partner, but he's a young star. He's our vice chair for clinical operations. And also he's a physician leader on musculoskeletal service line. He's a young star in academy, especially in knee and hip society. And we also have 3 physician assistants, Nick, Chad, and Tracy. So with their help, our quality of life, change a lot. And the division, probably we perform around 1,200 to 1,300 total joints every year. We got a referral from around the state and beyond. And the fellowship has been long-standing. We have 2 fellows every year. And we do have well-funded basic science research and clinical trials. If you look at this chart, we have currently running 2 NIH grants, 1 DOD grant, and several industrial grants, and 2 national clinical trials with PCORI and also the obesity in total knee replacement. We have a chief resident and a PGY-2 resident on service every rotation. Sometimes we have an intern on the service also. We make sure our residents get more than enough hands-on experience on the service. And from my experience, all our residents loved to rotate on joint service. Now let's start talking about total hip replacement. So if you look at the title, we're talking about the operation of the century. I didn't say this. I'm going to show you the literature to confirm this. But we need to know a little bit of history. Total joint replacement has been here for many, many years. So it's not something new. And you see 1930s, Smith-Peterson, we all know about Smith-P approach, right? This is the pioneer developed first actually total hip replacement, not a truly hip replacement, but a femoral head resurfacing. And then later on, you see all those big names, Judith Brothers, Austin Moore. You know, when I was a resident, you know, Austin Moore was the really only prosthesis we used. It's very interesting. It's a monoblock. You just open the hip up and just you know, squeeze that in the femur. That's it. And later on, truly, it was Dr. Chanley revolutionized total hip replacement with the low fraction Turk principle applied to the joint, you know, total hip replacement. He used a small metal head, but a large polyacetabular shell. So take time to wear out the polyethylene liner. And he also lateralized trochanter to you know, make a hip more stable by mechanically more you know, advanced. Since that time, total hip replacement technology has advanced. So I'm going to show you more along this line. So who gets the total hip replacement? Osteoarthritis is the most common indications, followed by post-traumatic arthritis, osteonecrosis, rheumatoid arthritis, hip deformities, you know, caused by FAI, femoral acetabular impingement, hip dysplasia that led to early age osteoarthritis. Last few years, femoral neck fracture become a hot topic. You know, total hip replacement also become one indications, you know, for the femoral neck fractures. So if you look at the United States statistics, in 2014, 370,000 total hip replacement were performed. By prediction, by 2030, total hip replacement is going to grow 171%, reach to 635,000 cases. We have a huge demand. We need adult recon surgeons. So I'm going to show you that literature also. This is a very successful procedure, relieving pain and restore joint function. In 80% of the patient, they can last more than 20 years. Very low risk for complications. If you look at epidemiology, in 2015, there was, well, 15 million doctor diagnosed arthritis in the United States. Of course, a knee is most commonly affected. The medical bill actually caused about a 3% of GNP. That's national produce. So it's huge. The cost is huge. And also, you want to pay attention that there are, you know, 8.4 million young arthritis. That's the age between 18 and 44. You know, people getting more active, play sports, more injuries. You know, this just arthritis is there. So those are the data. You can find those data at a CDC website. You know, cost and you know, arthritis projections. So how to establish diagnosis? You need a same thing, history and a physical. You know, this is the first step. You really wanted to have a face-to-face interview with the patient. You wanted to know your patient. You cannot escape this step. So you want to get a chief complaint. You want to see what's the patient's goal. You want to see if they have a history of infection or previous surgery. Do they have an existing implant? So what are comorbidities they have? A heart problem, a lung problem, or diabetes, or rheumatoid, all those stuff. That will affect your decision making and also dictate the outcome of your surgical treatment. And also, you want to personally do a physical examination. You have to touch your patient. If you don't touch your patient, you will not have a good relationship with your patient. You cannot establish the trust. So you have to touch your patient. Put your hand on their knees. Check their range of motion yourself. You know, this is the only way to figure out what's really going on with the patient. Do they have a leg length discrepancy? How they walk? Do they have a spinal problem? Flexion contracture of the hip or knees? How about their contralateral limb? So the reason for doing this not only you know the patient, you also want to know pre-op function is going to dictate post-op outcome. So you want to set up expectations for your patient. So you have a same goal, so you're on the same page. And then you want to do a radiographic study. Generally, we do X-ray, that's adequate. Many community doctors, they do MRI, do CT scan, probably not necessary. We generally do AP pelvis and affected hip AP and across table lateral. Sometimes we do frog lateral for young patient if they have osteonecrosis or femoral acetabular impingement, FAI. So you can see femoral head and the neck better. This is a or cross table lateral. If a patient got a knee flexion contracture, you can lower down the corner of the bed so the knee can flex over there, get a better X-ray there. And a good AP and a lateral view, you can adequately see the hip pathology, also proximal femur and anterior posterior femur. You can see the bow of the femur. You can see anteversion of the femur neck. So rarely, if you cannot establish diagnosis and then advanced imaging study like MRI, CT scan may be needed. So this is how you do frog leg lateral view. And then on this frog leg lateral view, you can see anterior femoral neck and anterior, lateral femoral head also. This is the most common area for osteonecrosis. So after you get a history, physical imaging studies, now you want to say, hey, do you have an indication for surgery? So if patient got a disabling pain, limited range of motion function, X-ray shown severe arthritis, they have failed NSAID treatment, physical therapy, hip injections, and then this probably is the time for total hip replacement. However, you also wanted to know if a patient is contraindicated, if they have a recent or current septic joint, that's absolutely contraindication. No surgery. You have to get rid of this infection. Or other relative contraindications. Patient got a uncontrolled diabetes, morbid obese, BMI more than 40, you may need to lose some weight. Patient is using cocaine, they need to stop that, right? Alcoholic, smoking, those are relative. So you need to work with the patient, improve their medical condition before you do surgery. So after you mutually decided to do total hip replacement, and then it's time of talking about how to plan your surgery. So surgical planning is the key to success for your surgery. So generally you need to, the goal is to restore normal hip biomechanics. We're talking about a hip length and an offset of the normal hip. You want to correct your affected hip, relatively similar to your normal hip. So you need to identify the landmark, leg length, cup size and position, stem size and position, where you're going to do the femoral neck cut. So if you look at this one, nowadays we use the digital templating. After templating, you can see this patient is going to need a 56mm shell, and it's a size 5 high offset stem, and a neck cut from the lesser trochanter to the neck. This is about 12.4mm. So before surgery, you generally know what size of components you will need. So this is critical. Sometimes, if you miss this part, you get an operating room if you don't have that size of implant available, and I think that's a big trouble for surgeons. And also you wanted to know bone quality. We're talking about a door index as a canal to calcar ratio. If it's less than 50%, like a door A femur, you can use the press fit stem. If you use, if this is more than 75%, look at this femur. This is like a tunnel, right? The bone, no cortex, no trabecular bone within the femoral canal. So it's very osteopenia, osteoporosis. You probably need a cemented, okay? So you need to analyze those to plan your surgery. And then you want to decide what's the choice of articulation surfaces. There are so many. You have a metal on poly, ceramic on poly, metal on metal, ceramic on ceramic. So most surgeons will use ceramic on poly. In clinic, there was no difference compare metal on poly and ceramic on poly. But metal on metal, you probably already know that's a medical disaster in our medical history here in the United States. So we don't use the metal on metal implant anymore. Ceramic on ceramic is the lowest wear rate, but squeaking can happen in about 5 to 10% of the patient. So patients don't like that. You need a revision surgery. This ceramic on ceramic. This is a oxynium, so they're made by another company. And then you want to look at a stem design. They have a cementless or press-fit stem. So this is a single wedge. This is a dual wedge. And here's a tapered, stem fixation at metaphyseal and diaphyseal junction. This one is type 4. This is extensively porous coating diaphyseal fixation stem. Those are generally used for revision surgery, but this is has been used previously for primary. Not that we rarely use this anymore. And then you have like modular metaphyseal fixation system for revision surgery and anatomic shape stem. So depending on surgeons, training background and their preference. And then another type is a cemented stem. You have a colored or colorless, but those are smooth surface. You can get a better interface between a component and a cement. So those are different design. And also for the acetabulum, we do have a cemented cup, also a press-fit cup. Rarely here in the United States, we use a cemented cup, but most surgeons use a cementless cup. And a design with the liner also have a different design. It's a flat surface, elevated, also lateralized, and inverted. You can like a phase change to increase the stability. And also to treat instability, look at this constrained liner design. So many different designs. The dual mobility is another acetabulum design to treat instability. And a constrained acetabular component, you can see here's a locking ring. They can lock the femur head into the acetabular, acetabular liner. So to treat, recurring dislocation or very, difficult to treat instability of the hip. So, and then let's talk about approach. So 3 approaches for total hip replacement: anterior, posterior, lateral. Many different names, but direct, we're talking about direct anterior hip is getting very hot. So this is a Smith-Peterson approach. We just mentioned probably the name. You guys can spend the time, look at, all their tissue plans, the nerve, vessel, risk, benefits, and risks. But I'm going to give you some conclusion. This is an anterolateral approach, or it's called lateral approach. And most surgeons use the posterior approach. They all have pros and cons. But the Dr. Grossman sent you that article for review. Basically, if you look at the anterior approach, there is a slight advantage for early recovery and the level of muscle damage. Infection is a problem with all approaches, but only complications are most troublesome with the anterior approach. The lateral approach provided the most stability compared with the other 2 approaches. But the posterior is most commonly used. It can change that to extensile approach with better exposure. So most commonly used for revision total hip replacement. So I'm going to show you a short video for posterior total hip replacement approach. So courtesy to Dr. Thomas Moran, I spent a few days at a hospital for special surgery, and I'm still using, well, I want to say modified. So here's how you do a very small incision on the skin, but as needed, and then you incise the gluteus maximus fascia, and then you split gluteus maximus. You put a retractor above the femoral neck and the inferior femoral neck to protect abductors, and then you incise shorter posterior rotators. You can see that piriformis here, and then the other shorter rotators here. So just to make sure you protect sciatic nerve, this is the posterior approach. Sciatic nerve is in danger. And then you tag the capsule and the piriformis tendon and ready for later repair. After that, you dislocate the hip, you do femoral neck cut according to your templating. So take the femoral head out, and then you expose the acetabulum. So you put an anterior retractor. And then you put a pin superiorly. I use a straight Holman to expose superior acetabulum. And then this is the posterior. So the inferior retractor. After this, the acetabulum can get exposed adequately, even with a small incision. You can see all retractors actually is offset with a curve. And you clean up the acetabulum, all the labrum, debride the labrum, and you ram, and then you insert your cup. I'm going to show you how to ram the acetabulum in another video. So you insert the acetabulum. You wanted to know the inclination and anteversion of your acetabulum component. I have another slide to show you that. And then you expose the proximal femur, and you do the canal broaching. So this is how you broach the canal first. And then you insert the stem, you do the instability check. So make sure the hip is very stable, and before you close your wound. So this is how you rim the acetabulum. You rim medially first, and center your rimmer, and maintain anterior posterior wall until you see the bleeding bone, so you can have a better bone ingrowth to your cup. So the implant insertion I just mentioned, surgeons use a different technique, but most of surgeons, you can do acetabulum first, and then you do the femur, but you have to get to know that you don't have much room to wiggle, about your stem version. You can do more on your cup. You can antevert more, you can, incline more, but the femur is very tight. You cannot change much. So that's why a lot of surgeons do the femur first and then do the acetabulum second. So you can decide how much anteversion you can do on the cup, and then you get a combined anteversion about 35 degrees. So that's the safety range of the hip range of motion. But the key is obtain intraoperative stability. Otherwise, don't leave the operating room. So because instability is a major problem for orthopedic, adult recon surgeons. So perioperative management, infection prophylaxis, we generally use 3 doses of NSAID, 1 hour before you cut the, do the incision, and then 2 doses after surgery. And we prefer use spinal together with ERAS protocol. And, we use the tranexamic acid, 2 grams, 1 gram at the beginning, and 1 gram at the conclusion of the incision. We rarely need transfusion, probably once, twice a year. Pain control, we use a multimodal protocol, and everybody got a physical therapy same day of the in the operation. And a DVT prophylaxis, generally for 6 weeks, we use a risk stratification protocol. And total joint replacement outcome, if you look at it, is excellent pain relief with significantly improved function and quality of life. 10 years survivorship, more than 95%. 20-year survivorship, more than 80%. So press-fit probably better than cemented in the United States, but the European data showing cemented has equal good outcome compared with press-fit. So this is where the title comes from, the operation of the century, total hip replacement. So I don't have to say anything more. You already hear from me, right? But the other thing I want to mention that joint replacement access started in even 2016. We have a supply side crisis. We need more adult recon surgeons. So be prepared. Next 30 years, you have a secure job. You have so many baby boomers, they need a joint replacement. All right, complications, it's very rare and it's very low. Most of the complications, surgical site infection, dislocation, like lens disc grammacy, those are very rare. DVTs, PEs, you can look at them. We probably don't have to talk about it too much. I just want to, with time considering, I want to show you one case here, 2 cases here. This is a 77-year-old female with right hip pain, BMI 33. And then look at the X-ray here. You have femoral neck fracture. And I treated at a community hospital with cannulated screws. And several weeks later, the internal fixation failed. Screw cut into acetabulum. So look at, this is a door B or C. So we did a cemented total hip. This is pretty much a new indication for cemented total hip replacement. And this is the one is very rarely seen. 43-year-old female with the left hip pain for 2 years. So she lived like this for 43 years. Just the last 2 years started to have pain. So failed all non-operative management. So this is a DDH, classic high dislocation. We did a CT scan. If you look at a true acetabulum here, it's very deficient, right? So this is intra-op X-rays. So we did a subtrochanteric femoral osteotomy in order to avoid sciatic nerve damage, and then reduce the proximal femur force, and then got this fracture fixed using SROM, the type of implant I showed earlier. So this is in PACU. This is a 6 weeks post-op follow-up. The osteotomy is still there, but no rotational stability fixed by this special design of the stem. You can see that. And 3 months later, fracture, osteotomy healed. Patient walk without assistance, no limp. So this is a great case to show. And adult recon really, truly can change patient's quality of life. So in summary, know your patient, know the risks, know their function, educate your patient, set expectations. Time for surgery, you don't want to wait too long. You want to make sure a patient have a good functional outcome after surgery. And you want to do surgical planning. Without a planning, is a plan to fail, right? You want to maintain surgical volume so you are skilled, you're experienced. So that way you can decrease the risk for complications. You want to have a team approach. So this way patient can have a good recovery. You have a happy patient, you're a happy doctor, okay? The team approach. Now I can answer your questions. By the way, this is a new orthopedic hospital. In a year also, we will move over there and start to see the patient. And your class is going to be the perfect time to join the team, enjoy state-of-the-art facility. All right, so what about the time? I probably used too much time, so we have 2 more.
That was outstanding, my friend. You covered all of total hip arthroplasty in 30 minutes. That's great. No question, that's the operation of the century. There's not an operation more successful in all orthopedics as far as removing pain, restoring function. And people who are debilitated with pain and have a limp and have loss of motion, that surgery can just absolutely change their lives. And the things that adult reconstruction doctors do for patients really is second to none. Sadly, though, with the advent of hip arthroscopy, it'll probably go by the way of polio, since I'll probably correct all these hips before they ever need hip arthroplasty. So sorry about that, Trey.
The backup for sports team. Yeah. We're a backup team. Okay.
So when I screw up these hips, Trey comes and saves the day. So he always looks like the hero for me. But so the raise hand function's available. If you guys have any questions for Dr. Cui, by all means ask. I mean, I guess the question everybody wants to know is, are there any questions from the crowd?
Not only just a hip replacement, anything, training. I was trained here at UVA. I have been here for a long time. Any information you need. I think this is why we're doing this, because we cannot really see you face to face. So we want to, interactive, any way we can. So please don't hesitate.
I think one of the things you'll get from this curriculum is just kind of how our faculty, just the approachability and the camaraderie amongst faculty. All of us we are all in your shoes at one point, both as medical students and as residents. And so we understand what it's like to learn a new skill and learning orthopedic surgery. I mean, you saw that video, reaming out someone's acetabulum. It takes a little while to build up that kind of confidence. And so, trying to get those skill sets established is really key. I think the residents on the call can confirm just kind of the autonomy that Dr. Cui gives in the operating room as far as how to learn those types of skills under some direct supervision. And eventually, once you start getting those skills, you'll find you're doing knee replacement, skin to skin, and hip replacement, skin to skin under his tutelage. So really good stuff. Thomas, do you have your cases ready? Thomas?
Yes, sir.
We have a couple of hands raised now. Garrett Berger, what do you got, my friend?
Hey, how's it going? I'm Garrett at Medical College, Wisconsin. So, Dr. Cui, we have a few adult recon surgeons that I spent the last month with, and some are very opinionated for the anterior approach, and some are very opinionated for posterior. Do you personally I know you showed the video of the posterior. Do you personally lean that way, or do you take it as a case-by-case situation?
Oh, actually, no. Because I didn't get trained for anterior hip, I have been doing posterior, for a long time. I do anterior Smith P for FAI though. I know that approach, but I just really, I didn't start. I don't have any training, so I don't want to go that route. Then I do posterior. I think, if you read that article Dr. Grasmi sent it to you guys, by the end of the day, it's all about, the surgeon's experience and your skill. Any approach, you can do a fantastic job for your patient.
Youssef, you have a question on the chat. You want to go ahead and ask that question?
Sure. So my question was, given that you mentioned lecture and also in the paper it talks about how the lateral approaches gives you a little bit more stability. So if you're advising a total hip for stability, would you go lateral on the second time, or would you still go posterior again?
I still go posterior. I only do, lateral approach for patients with, Parkinson's disease, alcoholic, or, they have a dementia. They don't know what they're doing. So I do take my resident, go that route for, a lot of femoral neck fractures. So occasionally, if a patient already used lateral approach for their joint, when I do revision, I go through that approach. But I normally don't do a new approach if I do revision. I do posterior.
As an unbiased bystander, the utility of the posterior approach cannot be understated. I feel like the posterior approach, the anterior approach has gotten a lot of sort of market-driven interest, and it's a great approach, don't get me wrong, but the tried and true, the Charlie, what has 60 years worth of outcomes is a posterior approach. The lateral approach has its own problems, getting into the gluteal muscles, you can get abductor weakness, you can get a superior gluteal nerve injury. And so I think that if you have comfort with the posterior approach, it's a fantastic way to get into the hip and get the hip out. We do have a guy, Dr. Brown, Tom Brown does anterior approaches. And so they are done here at UVA. But again, the posterior approach really has a great track record. Sam Eller, do you have a question?
Yeah, hi there. Just a quick question about the training at UVA. Is there one approach that you see your residents see more of and be more comfortable with, or do they get a good mix of the different approaches?
Oh, you got a good
from a resident perspective. I think we get a good mix of all the approaches. Briefly, I'll say that a Friday with Dr. Cui is one of the best days you will have as a resident, because a happy Dr. Cui is the best teacher and the best person to operate with. He makes you want to go into joints, even if you really want to go into sports. Also, I'd say we get a posterior approach with Dr. Cui and Dr. James Brown. We get anterior approach training with Dr. Tom Brown at UVA, and then there are 3 guys in Roanoke who do exclusively anterior, some on a Hanna table and some like on a slider table. So we get even a different table approach down here. And then we also do a number of hemis through the posterior approach. And I'll say, Dr. Cui, I thought of you just yesterday doing a hemi as I was closing it up. And I remember when I was an intern and I passed the needle through like 3 times before I had a good bite. And I thought, man, I remember when he told me I was doing more harm than good. I promise you yesterday I did more good than harm during the closure. So we get a very wide breadth of experiences with all the different exposures. I think it's like perfectly balanced so that we can do them all.
Thanks, Matt. That's Matt, DC PGY-4. What does your shirt say? Birds aren't real?
Yeah, it's sort of like a meta commentary on disinformation. I certainly believe that birds are real, but it's a tie-dye shirt. I'm just trying to put out some good vibes tonight for the audience.
Oh my God.
Birds are real.
That's awesome.
Yeah. Jesse Wang, do you have a question?
Hi, thanks Dr. Cui for the wonderful presentation. I'm Jesse from Wisconsin. One of the things that I've read is that uncemented hip stems seems to have lower periprosthetic fracture compared to cemented. I was just wondering what you think the reason that is.
So the reason actually is very clear. All press fit, you have to use the broach to broach very hard to achieve original stability for your stem. So for cemented ones, you don't have to do that. You want to cement it to work for you. So again, if you're a good surgeon, you pay attention to what you're doing. I don't have an interrupt, that kind of fracture with press fit stem.
Thank you.
Mary Hennekes, do you have a question? Can you?
Yeah, I do. I asked it in the chat first because I'm Zoom inept and can't figure out how to raise my hand. But I was just curious whether or not when you do these posterior lateral approaches, if you repair the piriformis tendon. I've seen it done both ways, and no one's ever really given me any good data on why you should or shouldn't necessarily repair it.
There is a very good reason, actually. That study won the Academy Award. So Dr. Tom Brown, that's another university, not our Brown. So he's an engineer. They did a study on the cadaver. You compare repaired without a repaired, and later on, clinical study showed similar results. From cadaver lab to clinical outcome study shown the same result. So you have to repair when you do the posterior approach. And now that's our OIT question almost every year. So remember that. Anytime you the question show you instability and everything else looking good, without the capsule repair, that's the reason causing instability.
Yeah, that posterior capsular repair ends up being pretty important. So in the experience I have is, I actually trained UVA too with Dr. Cui and Dr. Brown, and that posterior capsular repair ends up being a really important part of the case. And they tag the capsule and they tag the piriformis to make sure it's repaired properly at the end. Lisa Friedman, do you have a question?
Yeah, my question is, how do you think that the rising prevalence of hip scopes and our understanding of how FAI leads to hip arthritis is going to change the prevalence of who's getting arthroplasty and its approach?
You want to answer that, Trey? Or are you going to answer that? Because I think we're going to eradicate hip arthritis. Do you know how, can I ask you a question, Lisa? Do you know how FAI was discovered or how it was sort of popularized as a concept?
Not from like a historical background.
Yeah, so historically, and Dr. Trey can speak to this since he actually operated with Dr. Gons, but in the early 2000s, like I'd say 2000, 2001, 2002, Reinhard Gons over, who was in Europe, started looking at young people who got hip replacements and tried to backtrack and identify a certain pathological phenomenon, which he later described as femoroacetabular impingement. And so there's a core article, so Clinical Orthopedics and Related Research, from 2003, when Gons and his group looked at early onset arthritis and was able to link it to cam and pincer FAI. And so that's where we first sort of started to understand what FAI came from. And so that's where the whole advent of hip arthroscopy, which really honestly evolved from open hip surgery. Gons is an open hip surgeon. He did all of his open through either a surgical dislocation or a mini open, as Dr. Trey can allude to, because he actually would have been operated with them. And that's where sort of the advent of FAI understanding came from, and hip arthroscopy has grown from that. So, Trey, if you have comments on that, since you actually were able to.
Too, I can add a little bit more on that. Professor Gons actually, again, he discovered this FAI. He designed a treatment either through Smith P or through surgical dislocation approach. So he also won American Academy of Orthopedic Surgeon award for that, either you call that a discovery or whatever, he has achieved. That's huge achievement. You can't win the Academy Award here in the United States. So I spent mini fellowship 3 months with him, did a lot of surgery. So I came back to UVA. I did a lot of mini open FAI until Dr. Grassman joined us, started to do arthroscopic FAI, that's basically, so I gave all my attention to him at that time. Arthroscopic definitely revolutionized this, treatment for FAI, basically.
But aren't you just taking away the symptom of the disease, not necessarily treating the underlying biomechanics that led to them getting the cam? Because nobody's born with a cam.
Keith, you want to talk about FAI? Is that what you want to do, Keith? Because
I think let's just keep going through these raised hands. Preet Patel.
I think we got to get to one more question, then we got to move to Thomas's talk.
All right. Sorry about that. I'll make it quick. Dr. Cui, I just wanted to get your thoughts on like the more contemporary single stage revision for periprosthetic hip infections and what you kind of think about that emerging trend.
Well, apparently more data is coming. So, and we're, the hip and knee society at this point, we're doing a multi-center trial and see actually if single stage really workable in the United States. The European data showing this is very promising, good data, and it's cost effective. But here in the United States, we're all based on high evidence, practice guidelines, because the two-stage that was a randomized clinical trials show better evidence. And that's why the academy, guideline has to be a 2-stage. But when we're getting more data, I think there will be a switch at some point if we get supporting evidence. But here at the UVA, we only do one single-stage revision for that for very AO patient cannot handle 2-stage. But we do recognize the downside with the 2-stage. It's a huge problem. Not only the cost, also injury to the patient. Their ability to mobilize and deal with 2 or even 3 surgeries. So we're working on it.
Awesome, thank you.
Yeah, you opened up a can of worms there going into the periprosthetic infection world, because that ends up being, that's the one thing about hip replacement, knee replacement that can really be problematic is if you have metal in your body and you get an infection, that's a disaster. And so that's why I think making sure you have good indications, you operate in the right people is really critical. And so I think part of the way you learn how to do hip arthroplasty is to learn what patients you do it on and what patients you do not do it on. Because even though you might be able to take away their pain, if you have a complication like an infection, that can be limb or life threatening and can really ruin your day. So sorry guys, we went on, that was great. I mean, total hips for 50 minutes, it's you can talk, again, it's one of the best operations we have. I like to keep this conference prompt at 1 hour. So I'll let Dr. Moran take it home with this discussion of our curriculum and our rotations. All right, buddy? Thanks, Thomas.
Hey, everyone. First of all, thanks for tuning in tonight. Really appreciate you guys taking time out of your busy schedule to listen to what we have to say and hear a little bit more about our program. I guess a brief introduction. My name's Thomas Moran. I'm one of the PGY-2 residents at UVA. I'm originally from Harrisonburg, Virginia. It's about an hour from Charlottesville. I actually did medical school here, and I was fortunate enough that they let me stick around for residency as well. Currently on my PGY-2 adult reconstruction rotation, and I'm actually really excited to talk to you guys about the curriculum. Curriculum specifically, because I think that's really one of the highlights and one of the kind of standout things about the program itself. But then of course you guys are going to be interested in hearing a little bit more about rotations and call. And I know those were questions that I had at programs that I visited when I was in your shoes. So for starters, this is a graphic that's lifted essentially directly from our website. And I'll probably say this more than once, but basically everything I talk about is referenced on our website. And if you don't pick up everything that you want to, you can always reference the website to help determine what rotations you'll have, when you'll have them, if you were to come to UVA. But I'll hit a couple highlights from this slide. For starters, our PGY 1 year is broken up into 6 months on orthopedics and 6 months doing off-service rotations. The orthopedic services that you'll rotate on as a PGY 1 are more heavy inpatient services. So that includes adult reconstruction, spine, and orthopedic trauma. And then time we spend off services on rotations that are relevant to us doing orthopedics. We'll spend some time in the surgical and trauma ICU, for example, and we'll see some of our sicker orthopedic patients kind of see what the other side looks like. Again, musculoskeletal radiology is a little bit more straightforward, why that's relevant to us. And then we also get to spend some time with our other colleagues from around the hospital and build relationships, because those are people we're going to be working with and taking care of patients for the next couple of years. PGY 2 year is really our heavy call year, and we'll talk a little bit more about call in a little bit, but primarily we're splitting time between the clinics and the OR. And our PGY 2 year also is kind of highlighted by our night float experience as junior residents. PGY 3 year, we get our first exposures to hand and foot and ankle surgery formally. We do get exposure to those on call cases that we'll see over the weekend. And certainly those patients that we see coming in through the emergency department. So it's not our first exposure to hand surgery and foot and ankle, but our first formal rotations on those services. And then PGY 3 year is also the first time we spend time down in Roanoke. And we do 2 separate 10-week blocks. So we spend a total of 20 weeks down in Roanoke, our 3rd year. our PGY 4 year, we began to be the chief resident on certain services. For example, the spine service. We also spend 2 more blocks down in Roanoke again. And then our PGY 5 years are chief year. And I think one of the things that's important to point out is that's the year that we get most of our oncology experience. We also spend time on, again, on the sports service, on the pediatric service, and an upper extremity service, and then of course the trauma service. This is another slide that kind of gives a breakdown as far as the amount of time that we spend on each respective service and then when we spend it. And I think the main takeaway point from this is that we really get a broad kind of balanced experience on all the services. And I think this is reflected in the sort of distribution of where we send our residents to pursue fellowship training. I think over the last 5 years, we've sent a resident into every division of orthopedics. I think that speaks volumes about kind of the broad experience that we get as residents. I'm going to segue into what our call schedule looks like, and it's just broken down by year. So our heavy call year is you're taking day call approximately once every 5 weeks. So it's usually on Mondays, and you rotate with the other residents that are in your intern class. As PGY2s, you take 1 day call, and then you also take 1 weekend day call and night call roughly every other weekend. As PGY3s and 4s, you enter the same call pool, and again, you take roughly a day and evening call every other weekend. During that time, you're also helping out with OR cases, helping out the junior resident that's on call. And I think it's also important to point out that the evening call is actually home call, although I find that oftentimes, we're busy enough with what's coming in through the emergency department that frequently residents won't be able to necessarily, go home for the entire, duration of their call period. And then as a PGY5, you're again rotating by weekend with your other co-residents in your class, and you're taking a full weekend call. And that, that comprises helping out with the OR cases for that weekend, helping out the junior residents on call, and helping to staff economy as a PGY5 resident doing weekend call. I think the next part is probably the part of the talk that I'm most excited about. And really, truly, this is one of the things that drew me to want to stay at UVA. I really enjoyed my away rotations that I had, but I think the kind of curriculum here, the emphasis on resident learning is really kind of second to none. I think a couple quick bullet points. We have a very robust academic schedule, and I think it's facilitated by the fact that we're all pretty much centrally located aside from our Roanoke residents. Our academic schedule is really protected time, and it's emphasized. It's not something that we just go through the motions on and take for granted. I think it's the appropriate balance of us being taught as residents by each other, by the faculty, but it also requires a lot of independent learning. So you have to be someone that's motivated to learn. Not everything is getting spoon-fed to you, but there is that nice balance where you're not having to do everything entirely on your own without any sort of formal guidance. Our academic curriculum is made up of a daily morning conference, and I'll touch on that a little bit more in a second. Every week we have a Thursday morning service-specific conference where we go over good teaching cases. We'll do OITE review questions, talk about really any relevant topics. We'll go over journal articles, stuff like that. Every month we have a journal club that's led by one of the divisions within the program. They'll pick out relevant literature, and we'll go around and discuss articles. Through each educational block that we have, we also do a cadaver dissection where we put sort of what we're learning into practice and work on approaches and relevant clinical anatomy. And then something that's kind of been piloted by Dr. Weiss, one of our orthopedic trauma surgeons, is a new Ortho 101 curriculum for interns that kind of teaches relevant clinical skills and things that are helpful for navigating the hospital, navigating call, things as big as splinting, things we do all the time, and then also how to work a fracture table and really becoming more comfortable with stuff like that. So it's a lot of really useful information, and Dr. Weiss has gone to a lot of effort to help pilot that as well. This slide kind of highlights what our weekly morning conference schedule looks like. Every Monday we have a fracture conference where we discuss the operative fractures that came in from the week prior. All the residents that were on call the previous week will present their cases, and we'll go through kind of how the patient presented, upon arrival in the emergency department, talk about relevant facts or relevant features of their presentation, and then we'll discuss what was done intraoperatively, show post-operative x-rays, so we can kind of talk about interesting learning points, and I think everyone takes a lot away from that. Tuesday is our core curriculum, and I'll touch on that in a second, but our core curriculum is broken up into blocks, usually by sort of anatomical regions of the body, and that allows those topics to sort of build upon one another, and then they're usually finished off with, like I said, that dissection down in the anatomy lab. Wednesday, we have our grand rounds and our QA conferences. Grand rounds, they do a really great job at bringing in relevant, exciting voices in the world of orthopedics. I think one of the recent standout ones that comes to mind was Dr. Robin West, who's a sports medicine physician up in Washington, D.C., and is actually the head team physician for the Washington football team. And it was really interesting to hear her talk and bring her perspectives to our program. Then, like I mentioned, Thursday morning we have our service-specific conferences, and then Friday is usually a conference focused on anatomy or basic science. We'll have presentations on radiology. We'll have the MSK radiology folks from really kind of broad-reaching curriculum that's presented to us, and we're required to prepare the night before so we can be active participants and really take a lot away from the curriculum itself. Essential readings are generally provided to us, often circulated amongst the residents, good review articles on a topic that's coming up. The attendings have also sort of gathered essential readings for their respective divisions that are sort of presented to us as sort of core reading to be done before starting the rotations, which is helpful for beginning. And then there are many different resources that are also available to us online, different review materials. We also get provided with Miller's Review. Kind of quick shout outs, Dr. Miller of our sports division. And then a lot of us were also provided with an AAOS book before starting residency. So a lot of resources are available. And again, I think you're kind of getting a sense of how robust our curriculum is. This is not meant to be fully digested. Slide really just illustrates the fact that our curriculum is very well thought out, planned out, and well executed. And this is available to us ahead of time at the very beginning of the year, so we can plan ahead, kind of know when we're giving our respective presentations, and also know what we need to be preparing for the next week or the week after to really get the most out of the curriculum itself. This is sort of zoomed in on one of our education blocks, and specifically, and you can see how, again, this is broken up by sort of a region of the body, this one being the knee. So we're not bouncing around, constantly coming back and forth, having to review things we haven't seen in a little bit. We kind of knock everything out at once, really hone in on one particular thing, and everything sort of builds off each other, and you're really able to get a lot more out of it. So that's all I got. Those are all the, I think the quick bullet points of our residency curriculum and call schedule. I'm happy to stay on the line a little bit longer and answer any other additional questions that might come up from the audience. Alternatively, I can be reached at my email address that's listed on the slide.
Thomas, thanks. That was great. I mean, really, honestly, Keith Bachman and myself, our goal, our mission is to create an experience here with training that provides you every resource you need in order to get everything you can possibly squeeze out of orthopedics. Tom Brown, who's one of my mentors in the joints department, says orthopedic residency is like drinking from a fire hose. And so the water's coming out so hard. And for me as a curriculum creator, one, I certainly take a lot of insight and advice from our residents. Like, what do I need to be teaching you? What do we need to be teaching you? Because it's really critical that we understand that, training now is different than training 10 years ago. And so we need to evolve. But two, we also need to make sure that we give you a curriculum that's going to prepare you for autonomy, prepare you for the orthopedic boards. So ABOS is this looming exam you take after you're done with graduation. You got to be able to sure you can pass that. And also we want to make sure we expose you everything so that if you can make a good decision as far as what you want to do in life. So most people are subspecializing, and so it's important for us to have everything covered for you. So Thomas did a great job kind of going over through everything. Just to let you guys know, we are going to have some small group opportunities with our residents in the next couple of weeks. So you guys can ask questions to our residents about sort of more resident-centric topics, like, where the call room is, and like how much money do you get in your meal card, and like, do you get scrubs and lead and stuff like that. So that'll be in the session at some point in the near future. Additionally, Dr. Bachman and myself are working on a sign-up sheet for all of us to meet with you individually. So either Dr. Bachman or myself in the next 4 weeks or so, and there'll be a sign-up sheet coming up probably either tonight or tomorrow, depending on when Dr. Bachman and I can get our calendars figured out. But that will just be 15 minutes, just chat with the PD. So that'll be opportunities to ask questions too. Because at the end of the day, what we really want to do is be transparent and let you guys know what we have here at UVA. So it's 9:07. I apologize. I wanted to keep this under an hour. So I'm not going to open the floor to questions on this specific topic, but there will be opportunities in the future, okay? So Dr. Cui, thank you very much. I really appreciate your insight. You've been a leader in this program for a long time, and I really look up to you. And you taught me what FAI was back in 2008. I remember your lecture when you said it, you talked about FAI, and I was like, I don't know what you're talking about. Now here I am, that's how I live. And Thomas, you did a great job. Thank you for doing that for me.
Well, it's a pleasure. So, I don't mind to stay online if anybody got a questions. Otherwise, send me an email. Our email all on the department website. Just stay in touch. I hope you enjoyed the lecture. I think Dr. Grossman, Dr. Bachman, they put in such a wonderful program. In this challenging time, this is really needed. And I want to thank you, and thanks to everybody for joining. The conference.
Well, thanks again, Trey. Yeah, his email is on the previous email I sent you guys. If you guys have a specific question for him. Finally, if you guys want to attend our morning lectures, by no means is it required. I don't want you to think that you need to, but if you want to just kind of get a taste of it, the one beauty of COVID is that you can actually just log into our morning conferences if you want to. Tomorrow, we're doing a hip dissection, which is kind of fun because, we've had 3 residents working on cadaver for the last 2 days, and there'll be some really cool things to look at. So you're welcome to log in. I'll provide you the information as how to log into that. That's at 6:30 tomorrow morning. But please, by no means think it's imperative or required or mandatory. I won't be looking for your name in the roll sheet. I promise you that. So again, we're just trying to show what we got. So Thomas, thanks again. Keith, thanks. Matt DC, thanks. Thanks to everybody who asked questions, and we'll see you next week, okay? Adios.